Our next presentation is entitled Socioeconomic Status and Bronchiolitis Severity Among Hospitalized Infants, presented by David Zheng from Massachusetts General Hospital.
Thank you all for coming out. My name is David Zheng, and I am actually not an MD. I'm a clinical research coordinator in the Emergency Medicine Network at Massachusetts General Hospital, also known as MNET. And MNET is an international research collaboration that aims to promote public health objectives through projects in emergency care. And today I will be talking to you all about our research on socioeconomic status and bronchiolitis severity among hospitalized infants. Sorry, one second. Which button? Perfect. Sorry about that. So we have no disclosures. So bronchiolitis is the #1 cause of hospitalizations for infants in the United States. And the costs of these hospitalizations have continued to climb over the years. Furthermore, infants hospitalized with bronchiolitis are at increased risk of developing recurrent wheezing and childhood asthma. And studies have shown that children with lower SES or socioeconomic status are more likely to present to the emergency department and subsequently be admitted with bronchiolitis when compared to the general population. Therefore, the objective of this study was to, among hospitalized infants, identify socioeconomic factors associated with bronchiolitis severity. MNET is currently conducting a multi-center prospective cohort study that enrolled 1,016 infants across 14 U.S. states from 17 hospitals from 2011 to 2014. This is part of the multi-center airway research collaboration and is the 35th iteration, also called MARC 35 or the WIN study. All infants had an attending physician's diagnosis of bronchiolitis. And we have a demographically diverse cohort with a median age of 3.2 months, 60% male and 42% non-Hispanic white, 24% non-Hispanic black, 30% Hispanic, and 4% other. Data for the current analyses were collected through a structured interview and physician chart review. During the initial bronchiolitis hospitalization episode, study staff collected data on the episode that led to admission with a structured interview with parents and legal guardians. And this interview included the SES factors examined in this analysis, namely estimated median household income per home zip code, parent-reported total household income, number of adults and children in household, and insurance type. Further clinical data on the episode was collected through a physician chart review of the patient's medical records, which included the primary outcome of this analysis, namely higher bronchiolitis severity as defined by receipt of intensive care treatment. And please note this is a two-part outcome in that an infant was considered to have had a higher severity bronchiolitis episode if they were either admitted to the intensive care unit and or received mechanical ventilation, that is CPAP or intubation. We found that estimated median household income per home zip code was the SES factor most strongly associated with bronchiolitis severity. Compared to infants with an intermediate estimated median household income per home zip code, those with lower MHI may have been more likely to have received intensive care treatment for bronchiolitis with an adjusted odds ratio of 1.59. However, higher MHI infants were significantly more likely to have received intensive care treatment for their bronchiolitis with an adjusted odds ratio of 2.05. SES is a complex construct measured in a variety of ways, but with that said, we found no significant associations for the other socioeconomic factors examined in this analysis, including the parent-reported income. However, this may have been because 30% of respondents did not answer the question about parent-reported income, and it's possible that the result for parent-reported income could have matched that of the estimated median household income had all respondents answered the question. However, given that we found such a strong association with the estimated income, we conducted a sensitivity analysis combining the estimated median household income with the parent-reported income into one key exposure variable. In this sensitivity analysis, we designated infants with high income status as those who have both parent-reported income and estimated median household income of greater than or equal to $80,000. We found that infants with high income status were even stronger, had an even stronger association with higher severity bronchiolitis and receipt of intensive care treatment with an adjusted odds ratio of 4.20. We then tested for clinical differences between estimated median household income groups to see if higher income infants were objectively more severe in their bronchiolitis, and they were not. We found no differences in pre-admission clinical presentation as measured by number of days since index breathing problem began, presence of apnea, oral intake by conclusion of the pre-admission visit, and degree of retractions. We also found no difference between income groups in receipt of mechanical ventilation alone or an index hospital length of stay, which is widely regarded as another proxy measure for bronchiolitis severity. What we did find was that higher income infants were significantly more likely to have specifically been admitted to the intensive care unit. We then conducted a replication analysis in a large analogous data set, which was the 30th Multi-Center Airway Research Collaboration, or MARC 30. This cohort comprised 2,207 children who had been hospitalized with a attending physician's diagnosis of bronchiolitis, and this replication analysis confirmed our finding with MHI. Finally, we conducted a meta-analysis combining the MARC 30 and MARC 35 cohorts, which also confirmed our MHI finding, in that lower income infants may have been more likely to receive intensive care treatment, and higher income infants were significantly more likely to receive intensive care treatment. While mechanistic research is limited, there are several potential explanations for how higher income status may increase the risk of higher severity bronchiolitis, two of which are the hygiene hypothesis and differences in the microbiomes of infants between income groups. However, our findings may also suggest an underlying disparity in the treatment of bronchiolitis. We found no differences in clinical presentation between income groups as measured by MHI or in receipt of mechanical ventilation alone. The fact that we found that higher income status was associated with specifically admission to the ICU may imply differential decision-making on the basis of SES in favor of admitting higher income infants to the ICU for their bronchiolitis. This may be explained by wealthier parents being more pushy in pushing for their child to be admitted to the ICU, even if their infant's illness may not be objectively or comparatively severe enough to warrant an ICU admission. Our study has several limitations. As mentioned, 30% of parents did not respond to the direct question about parent-reported income. However, the fact that our sensitivity analysis showed that high income status infants were at even higher risk of intensive care treatment lends strength to the association between higher income status, however measured, and bronchiolitis severity. Also, it's important to note that the zip code captures environmental factors other than the monetary wealth of a neighborhood that may lead to higher severity bronchiolitis episodes, such as, for example, proximity to roadways and air pollution. Also, the structured interview conducted with parents and legal guardians did not include a question about educational level, which is widely regarded as a fundamental correlate of SES. However, MNET is currently conducting long-term follow-up interviews with participants to assess educational level, and in the future we will use these data to examine the association between educational level and bronchiolitis severity. Lastly, our study consisted of infants admitted to urban academic hospitals, so it's possible that our findings are less generalizable to other settings such as non-urban, suburban, rural, and non-academic medical centers. In conclusion, we've identified estimated median household income as a risk factor for the intensive care treatment of bronchiolitis. Specifically, higher income infants, as measured by MHI, were significantly more likely to have received intensive care treatment for their bronchiolitis. We believe that our work encourages further research on the observed associations and their mechanisms, such as what are the environmental factors associated with zip codes and neighborhoods that may lead to higher severity bronchiolitis episodes, and whether there exist socioeconomic disparities in ICU care. Thank you.
Thank you, This abstract is open for questions, 2 minutes.
Yeah, it's David Harriman from Yale. A question, did you look at confounders like pets and smoking status?
So yes, our multivariable model adjusted for several confounders, so I can show it to you right here. Is it possible to go back to the slides? Right, so we adjusted for age and sex, race and ethnicity, prematurity, and then all of the clinical factors that I'd mentioned in the presentation. And factors were included as covariates if they were suggestive in unadjusted analyses or if they were considered potentially clinically significant. We did not adjust for pets, but that's something that we may consider for future analyses. Yeah, thank you.
Hi. Very interesting. Given it's a multi-center study, did you adjust for the hospital itself? I'm just wondering if hospitals that tend to admit more to the ICU for this condition treat higher income patients.
Yes, of course. So we did adjust for clustering by site. So that includes, whether there existed between hospital differences in ICU admission or also in physician use of mechanical ventilation.
Other questions? Okay, thank you very much, David.
Wonderful.
Thank
Thank you,
you.
David. Congratulations.